Hello, my name is Glenn Harris, and I am a third-year medical student at Vanderbilt University. I'll be presenting today on the role of occupational therapy during stroke recovery and rehabilitation. Importantly, entire books have been written on this subject, so this talk will only cover a few of the diverse services offered by OT. This talk is targeted towards medical students and neurology residents to help them better understand the services offered by OT after stroke. To begin, stroke is a widely prevalent disease within the U.S., affecting nearly 1 million people annually. Stroke tends to be a disease of older adults, with 2/3 of those affected being over the age of 65. Rehabilitation is challenging, and the American Heart and Stroke Associations have released thorough guidelines emphasizing an interdisciplinary approach. This may include physicians, namely physiatrists, as well as speech-language therapists, physical and occupational therapists, and rehabilitation nurses. Despite OT's omnipresence in the hospital, there remains substantial confusion about what exactly they do and the services they can provide. The services offered by OT vary depending on the setting of care. In the acute setting after a stroke, OT's #1 priority is to begin discharge planning, according to expert opinion. Literature also supports beginning rehabilitation as soon as the patient is able to do so. Other key areas of focus in the acute setting include patient comfort, positioning, mobilization, and beginning to retrain the patient on self-care. Following discharge, the patient may go to a rehabilitation center, either an inpatient rehabilitation facility or a skilled nursing facility. While PT and OT will collectively decide where to send the patient, it is important to remember that patients sent to an inpatient rehab facility must be able to tolerate 3 or more hours of therapy per day and not have any medical needs requiring skilled nursing management. In these settings, OT will tend to focus first on the patient's ADLs, such as toileting and eating, though IADLs may be included as part of the therapy as well. In the outpatient setting, OT tends to focus more on IADLs, including driving, as well as returning to work and ensuring that the patient can still enjoy leisure activities. While there is some evidence to indicate that an earlier referral to lower level of care after the acute setting is associated with improved outcomes, these studies have been criticized due to the different patients who are fit for different levels of rehab shortly after their stroke. One of OT's most notable skills is the ability to fit patients with assistive devices. While these do include things such as wheelchairs and canes, there's also an array of assistive devices tailored to stroke patients. Since upper extremity weakness is common after an MCA stroke, one-handed devices are key. For example, this nail clipper may be used one-handed in order to assist with grooming, an ADL. Many other devices exist to assist with ADLs and IADLs. Here, we see a woman with impaired left arm function using a device to hold her hair dryer while she brushes her hair. Likewise, OT may order devices for one's motor vehicle, such as a left-sided gas pedal or a turn signal crossover device. These devices can help someone who has lost full use of one of their extremities to regain the ability to perform necessary activities. OT is uniquely positioned following strokes of the PCA in that they can do home visits and make recommendations to assist those with visual impairments. Of note, there is at least one study that has found that visual impairment and stroke may have a significant impact on the mental health of older adults. In this single study of adults age 65 or older, stroke and visual impairment were independent predictors of depression as determined by the geriatric depression scale. However, further reviews did not demonstrate an association between age and post-stroke depression specifically, a known syndrome affecting about 30% of patients following stroke. Regardless, it is important for OT to assist patients who have visual difficulties following strokes. During a home visit, an occupational therapist may recommend increased illumination and contrast in familiar settings. Examples would include the use of halogen and fluorescent lights, while being careful to avoid glare, dark soap on a white sink, or black text on a white background when making a PowerPoint presentation. In this series of images, one can appreciate how visual impairment can affect one's ability to complete ADLs, as seen in this woman who is unable to dress herself correctly in this low-contrast, monochromatic shirt. An OT may therefore recommend switching to clothes with more designs and contrast in order for her to better be able to find the armholes. Finally, I would like to touch upon an area which is often taboo, even for healthy adults: sexual function. Though providers may have difficulty talking about sexual activity, the American Occupational Therapy Association, or AOTA, considers it to be an ADL. To that end, OTs may receive specialized training in this area. With healthy aging, women may experience atrophic vaginitis, shorter orgasms, and decreases in the size of several reproductive organs. Men may have more difficulty with erection and increased refractory period following orgasm. Some of these changes are also seen or exacerbated following stroke, so OT may be useful for both stroke patients as well as healthy adults, where appropriate. Changes more specific to stroke include decreased libido and decreased self-esteem. OT will work around a patient's deficits in order to provide them with optimal fulfillment. For example, in a patient with hemiplegia, OT may recommend having the partner lie on his or her plegic side with the other partner anterior. This position may be adopted by both same and opposite sex couples and allows for the plegic partner to freely use his or her unaffected limb. Likewise, impaired motor control may require a change in coital positioning. For example, one partner may sit in a wheelchair, which may help to break the barrier of the chair being used only for transport and could also help remove some of the stigma associated with a wheelchair. In conclusion, OT is an important part of the stroke rehabilitation process and offers a multitude of therapies imperative to a patient's future ability to complete ADLs and IADLs to maximal ability. I hope you found this presentation helpful in clarifying OT's role after stroke. Thank you very much.